Okay, good. It's full screen now. Yeah. All right. Good evening, everyone. I'm Christopher Spears. I'll be our MC for tonight. I'm from Our Revolution Blue Hills, and we'll be hearing from 4 wonderful presenters for our Medicare for All Forum. Firstly, we'll be hearing from State Representative Lindsay Sabadosa representing in the Massachusetts House of Representatives. We'll be discussing the Massachusetts state level Medicare for All plan. Dr. Alan Myers of the Massachusetts chapter of Physicians for a National Healthcare Program. We'll be discussing the medical benefits of a Medicare for All plan. Economic professor Gerald Friedman, professor at the University of Massachusetts, will be discussing the economics of Medicare for All. And lastly, David Cohen, who serves on the board of MassCare, a coalition of Massachusetts organizations working to establish a single payer healthcare system in Massachusetts, will walk us through how we can continue the momentum for a Medicare for All system here in the state of Massachusetts. Once again, I am from Our Revolution, Massachusetts. Our Revolution, Massachusetts is a grassroots organization working to build a statewide movement by fighting for economic, racial, social, sexual, gender, and environmental justice. We were inspired by Bernie Sanders' presidential campaign, and we are working to continue the political revolution via 3 planks: building a progressive party, fighting to win progressive policies, such as Medicare for All and a Green New Deal, and electing progressive champions. And we'll be working on that this year during the midterms. Our Revolution, Massachusetts has affiliates and caucuses throughout the state of Massachusetts. And we would be happy to have you be a part of that. If at any point during this you would like to work with Our Revolution Massachusetts via volunteering, there'll be links for that in the chat. And if you don't have time to volunteer and you would instead like to contribute via a donation, there'll be links in the chat to do that as well. It's common practice at Our Revolution forums for us to have a invocation to start things off. I'll proceed. We recognize that we meet this evening on lands taken from Indigenous people. We recognize that we live within the American capitalist system founded on slavery, a system that established a legacy of violence and selfish acquisition that includes mass shootings, racism, sexism, homophobia, support of oppressive foreign governments, and economic inequality. We stand with the working class and their rights to dignity, a living wage, competitive benefits, and a robust and affordable health care. Through forums like this one, we endeavor to educate the public on these complex issues by finding constructive solutions regarding a new way forward. This forum will mostly be on fighting for a Medicare for All here on a state level here in Massachusetts. But before we get into that, I would like to give some updates regarding the momentum that Medicare for All has been having on a federal level. In this past February, the Labor and Education Subcommittee in the U.S. House of Representatives had a hearing on Medicare for All. At this hearing, Robert Reich, former Secretary of Labor, and Pramila Jayapal, chair of the Congressional Progressive Caucus, spoke out in favor of Medicare for All. And this Tuesday morning, March 29th at around 9 a.m., the House Oversight Committee, whose membership includes Alexandria Ocasio-Cortez, Ilhan Omar, Jamal Bowman, and Cori Bush, will hold a hearing on Medicare for All. Since August of 2021, the federal Medicare for All bill in the House of Representatives has gained 4 new co-sponsors, bringing the number of co-sponsors to 121 in the House, which is the most co-sponsors the Medicare for All bill has ever had. And lastly, Senator Bernie Sanders has announced that in the coming days, he will be resubmitting his Medicare for All bill in the Senate. Okay. All that said, I would like to present our first speaker. Sorry. Lindsay Sabados, elected in 2019. Representative Sabadosa is the first woman to hold the first Hampshire District State Representative seat. She helped fund the Western Mass Safe Communities Act Coalition and is the lead House Speaker for the Medicare for All bill. I'm proud to have Representative Sabadosa here to speak with us today.
Thank you so much, Chris. And I can share my screen, correct?
Yes.
Okay, let's see if this all works. Perfect. Share. And we'll start. All right. I guess I have to do the requisite. Can everybody see the sharing of the screen?
I can.
All right. Yes. Wonderful. Well, thank you so much, everyone, for being here this evening to hear about the Medicare for All legislation in the State House and to, I guess I'm going to say, to get more involved in the fight for Medicare for All, although I know many of you on this call are already really passionate about the topic and have been doing a lot of organizing work. So thank you for that. I'm going to go through the bill and hopefully we'll be able to answer any questions. I was thinking a lot about this legislation in recent days because some of the pushback that we get from the bill, and we will go through it sort of part by part so you'll fully understand it. But some of the pushback that we get is that this legislation doesn't answer all of the questions that we may need to answer to implement a Medicare for All system. We don't exactly spell out how everything is going to be transitioned, but what the legislation does is it sets up the structure to transition to a Medicare for All system. We don't pretend that we're going to know all of the answers today. As I think we've all learned from the pandemic, it's almost becoming mundane to say it, but we can't predict the future. And so for us to try to put into a bill right now that may not be passed for another few years would be silly. We need to try to create the framework, figure out how we pay for it, move that forward, and create the healthcare trust, and then appoint the right people to answer all of those questions. So without further ado, an act establishing Medicare for All, which is H 1267 and S 766, filed by myself, Rep. Denise Garlick, and Senator Jamie Eldridge. The bill is currently with the House, the Joint Committee on Healthcare Financing, and there has been no decision yet as to what will happen to the bill this session, although to be realistic, I do not think they're going to pass the bill out of committee. But here we go. So what does the bill do? Fundamentally, it declares that healthcare is a right, which is something that has not been declared in this country. It eliminates copays, deductibles, coinsurance, or we could just simply say it eliminates cost sharing. It creates the healthcare trust, which I'm going to talk a little bit more about as we move forward. But fundamentally, the healthcare trust would be the entity responsible for making payments for healthcare. It's very important when you're advocating for this bill that we make it clear we are not talking about a system that replaces doctors and nurses. It's not a nationalized system, it's a single payer system. So we're really just talking about how we pay for healthcare, not how we provide healthcare, although I think the bill could lead to really significant improvements in that arena as well. The bill levies a payroll tax to fund the trust, and it sets forth all covered care. That is going to be my favorite part. It's always my favorite part of this presentation. So, what is a healthcare trust? A healthcare trust, I think sometimes we could almost think of it as another branch of government, although it would fall under and be involved with Department of Health and Human Services, but it would have independence. And it would pay for all medically appropriate health care performed by eligible providers or facilities chosen by the residents. So that's why I say this is not a bill that talks about how you get health care, it just talks about paying for it. The bill also makes sure that we're able to fund capital investments so that there are adequate healthcare facilities and resources. I think this is really important because if you do not live in the Boston area, sometimes our facilities look different, and we want to make sure that that is equitable across the state. So this is one way that we could restore some regional equity to healthcare. Who is eligible to receive care? So we're really following the same guidelines as Mass Health. And so anyone who is a resident of Massachusetts, and then non-residents who work more than 20 hours in the state and pay state taxes. We also want to make sure that we're including non-residents who require emergency treatment. Now, this is something that is already done, and if you were a citizen of Massachusetts, a resident of Massachusetts who has Mass Health and had to travel out of state, there are rules that already govern how that is handled. So we're not really inventing the wheel in this section of the bill at all. We're really using those principles that we've already put in place and that we know work. Who is eligible to provide care? Now, again, we're not in the business of telling people where they have to go get care and what doctors and nurses they have to see. That is the business of health insurance companies. That's not what we're trying to do here. So we make this section really broad. Providers who are licensed to operate in Massachusetts, that seems like a given. Providers who've signed an agreement with the trust. And then, of course, providers who follow state and federal guidelines. We, of course, want to make sure that they're safe staffing, that they're meeting quality of care standards. And then we do give the trust the authority to set any additional requirements because, again, it's very difficult to only legislate for current situation. We have to think of what may happen in the future. And so we give those expanded powers to the trust. Now, the healthcare trust is governed by a board of trustees. We maybe should have a better name for it, but we do call it a board of trustees. And that would be 29 different members. And this is where I say we don't in the legislation spell out how we transition, but we allow people who have expertise to do so. So, of course, we have the Secretary of Health and Human Services, the Secretary of Administration and Finance, Commission of Public Health. I'm going to go a little quickly through these slides because there's a lot of information. You'll see that there are 8 members appointed by the governor, and we really tried to make sure that the members of this trust are people who have expertise, who deliver direct patient care, who are nominated by a disabilities rights organization, who have expertise in mental health care, a healthcare economist, also people appointed by the Attorney General. There we really tried to dig in to make sure that labor was fairly represented, to make sure that organizations that advocate for single payer are represented, experts in racial health disparities, women's health care. And then finally, we have 8 members who are elected by the citizens of the Commonwealth. Now, we used the Governor Council districts in order to find those 8 members. Again, it might not be the best solution, but it's kind of working with the current system that we have. So that would be the members of the healthcare trust. Then the board of directors shall hire an executive director. So the board director is not someone who's appointed, it's someone who's hired by all of those members. And that person's job is really essential to establish what the enrollment system is, to seek the necessary waivers, because implementing this legislation does require us through the 1115 waiver to seek federal permission to be creative with our federal dollars. So that's an important piece. also really important that we elect a governor who supports Medicare for all for that very reason, because that is something that comes through the executive office. We also give that executive director the ability to negotiate prescription drug prices, medical equipment prices, establish and negotiate reimbursement rates, develop the payment system for paying providers. You'll note that within the bill itself, it doesn't say this is how you do it. It says these are the powers that that person has. And again, I think that's an important distinction, because people will ask you questions while you're advocating for this bill, and that is always the response. The executive director also appoints the heads of 5 operational divisions, and you'll note, and it's probably because I'm from Western Massachusetts, but I keep bringing up the regional divisions because we want to make sure that there is equity across the state. But we also have planning, informational technology, administrative, and quality assurance. Finally, I told you this was my favorite part, the what is covered part. And I'm going to, well, I know Jerry Friedman is speaking later, so I won't say too much except that I think he is the wizard of economics, because he is able to create a system where we can pay for all of these things to be covered, and has the numbers to prove that it can be done. So basic things that you'd think: regular prevention, diagnosis, treatment of illness and injury. But the parts about Medicare for All that I really love is that we don't look at people as if they are broken up into little pieces, and maybe we'll cover that and maybe we'll cover this. We cover mental health services, behavioral health services, substance misuse, maternal care, prenatal, perinatal, family planning, and then long-term services, including home health care, hospice, language interpretation, dental, vision, hearing, prescription drugs, and then, of course, medical equipment. So I think this piece of the bill really speaks to the fact that our current system is very, very broken. I do not know about most of you. I do not have health insurance, and I have health insurance through the state of Massachusetts that covers well, maybe it covers a third of these things, but it doesn't cover most of them. But we could, in fact, have a system that does that. And that is why this transition is so critical, because really people deserve to have health coverage that covers their whole body. So, how do we pay for it? I'm sure Jerry's going to dig into this a little bit more, so I'll leave more of this to him, but I'll just say very simply, this is a payroll tax. Now, part of the reason it's a payroll tax is because of how Massachusetts taxes work. We have a flat tax in the state, and it just makes sense to go this way rather than to do anything else. And we want it to be progressive as well, as progressive as possible. So the employer would pay a payroll tax of 7.5%. The employee would pay 2.5. I always like to highlight that if you're in a union, that's a place where there could be some bargaining and negotiation, right? How much the employer pays versus the employee. And we exempt the first 20,000 of payroll. There's a surtax for larger employers, so those with over 100 employees, a 10% tax on the self-employed, and a 10% tax on all unearned income above 20,000, which does exclude Social Security, unemployment, pension. So that is the bill in a nutshell, and that's a very fast presentation. But if you have questions, I know there's a Q&A at the end, but if you have more in-depth questions and you really want to dig in, I've had people reach out and say, can you sit down with me and go through my financial situation, because I want to know if this would save me money, or if you have a business and you want to figure that out, I'm very happy to do those things. So this is my contact information, and I will look forward to the Q&A to chat more. Thank you.
Thank you, Representative Sabadosa. Our next speaker will be Dr. Alan Myers. Dr. Myers is a pediatric specialist in Cambridge, Massachusetts, with over 40.
Chris, you're on mute.
Yeah, thank you. Thanks, Representative Sabadosa. Our next speaker, Dr. Myers, is a pediatric specialist in Cambridge, Massachusetts, with over 40 years of experience and is a long-standing member of Physicians for a National Health Program. I'm proud to introduce Dr. Alan Myers.
Hi, can everyone hear me and see my screen? Hello?
We're good.
Okay. Well, thank you for that introduction. And yes, I was a founding member of Physicians for National Health Program back in 1986. So we've been at this for a while. And I represent PNHP on the board of Mass Care, which is the coalition that's working to advance single payer legislation that Representative Sabadosa just told us about, and we'll be hearing more about it from Dave Cohn later in this session. So let's start by acknowledging that the COVID-19 pandemic has shown a very harsh spotlight on the dysfunction of our current healthcare system. So here's an anecdote. Back at the outset of the pandemic 2 years ago, a 17-year-old boy in LA County, sick with COVID, stops at an urgent care clinic because he's very sick. They refuse to see him because he's not insured. They tell him, go see your closest public hospital, and en route there, he dies. Now, of course, we have no way of knowing, could his life have been saved had he been seen at that initial clinic? But I would hold that this is emblematic of where we're at. And in fact, if we look at the data, we have suffered more deaths more mortality per population than any other developed country. You can see us on the far left, with the exception of Russia, and we might say they shouldn't belong on this graph at all because they're not really a developed country. We have other data that suggests that 1/3 of COVID-19 deaths and about 40% of infections were linked to a lack of health insurance. But even if you have health insurance, if you are unlucky enough to get sick with COVID and get hospitalized, for example, with COVID pneumonia, the average patient with private health insurance admitted for COVID is going to spend almost $4,000 out of pocket in addition to what their private health insurance pays. Yet, during the pandemic, at its height, 5 of our largest health insurers reported more than $11 billion in profits in the second quarter. That's at the height of the pandemic last year. So that brings us to what we might consider the US healthcare paradox, that amongst all wealthy nations, we in the United States have the highest costs, the highest rates of uninsured and underinsured persons, and the poorest performance. Let's tick through each one of that, starting with healthcare expenditures. This green bar on top is what we're spending on average in the most recent year, 2020. It's about $12,000 per person. That is more than twice as much as the average of comparatively wealthy nations, and well more than twice what Canada's spending. Fix this graph in your mind because we're going to come back to Canada. And this disparity between what we're spending and what the other wealthy nations of the world are spending is not getting less, it's actually getting greater over time. In coverage, the most recent census data we have from 2020 tells us that in 2020, 8.6% of the population, 28 million people in the United States, lacked health insurance for the entire calendar year, and that's an increase of 1.8 million from the previous year. Does it make a difference to have health insurance? It sounds like a silly question. Of course it matters. But in fact, when we ask questions like this, we like to have some data to examine. Here's a study by Will Handler and Himmelstein from a couple of years ago, where they held everything that they could constant in terms of social economic status and health status, and they found that there was a 16% increase in mortality solely attributable to the lack of health insurance. That is a 16% increase in your mortality rate simply because you're uninsured. That's the body count from not having health insurance. Performance. Periodically, the Commonwealth Fund issues this mirror report. The last one was last year, which looks at comparative performance of healthcare systems in the developed world. The US ranks last overall, despite spending far more of its GDP on healthcare, last on access to care, administrative efficiency, equity, and healthcare outcomes. Another way of looking at this is on this graph where you see health system performance on the y-axis, spending on the x-axis. Here are the comparably wealthy nations clustered in this area of the graph. We're out here. We're the outlier. Another way of looking at this is life expectancy plotted on the y-axis versus expenditures on the x-axis. And again, there is a relationship here between all the world's developed nations. We are the outlier. We are doing something uniquely bad in trying to get healthcare, adequate healthcare to our population. So it's no surprise that this Robert Wood Johnson Foundation survey from last summer found that a majority, more than a majority, 56% of those surveyed in a random survey reported they had cost-related problems in accessing care in a variety of domains. They couldn't see their physician when they needed to, their clinician couldn't get a treatment, couldn't pay for medication. In this Kaiser survey, 29% of respondents did not take a prescription medication as prescribed because of cost barriers. We have data specific to Massachusetts that we can look at. In this state, Massachusetts, in 1 year, 51% experienced healthcare affordability burdens. Nearly 3/4 were worried about affording healthcare going forward, a quarter delayed going to the doctor or having a procedure due to cost, and 69% agreed the system needs to change. Medical debt. This survey from last month found that 56% of Americans owe medical debt. 1 out of 4 of those, it's $10,000 or more. Almost half of people with medical debt are putting off buying a house because of it, and 14% are planning to declare bankruptcy from medical debt. Now, if we step back and look at the big picture, this graph represents insurance coverage across the population, all age groups. So we have more than half, about 54%, are dependent on employer-based private health insurance. We have about 18% each covered by Medicare and Medicaid, about 10% directly purchasing their policies. Here's your 8.6% uninsured. Only 3% on the ACA marketplace, and about 4% getting their health coverage through the military. So what's the problems with private health insurance for that 54% of the population, the majority who relies on it? Number one, administrative complexity adds expense to the entire system. Think about it. You have hundreds of insurers issuing thousands of policies that change constantly. It takes an army of administrative staff and energy to keep track of all of this. So it's no surprise that it looks like this. Over 50 years, the growth in physicians, as represented by this yellow portion of the graph here, is dwarfed by the growth in blue-green here of managers and administrators necessary to deal with this hopelessly and needlessly complicated system. Bloomberg Businessweek pointed this out a few years ago. The reason healthcare is so expensive, insurance companies. The arrangement that accounts for much of the difference in health spending between the US and other places is the enormous administrative overhead costs that come from lodging healthcare reimbursement in the hands of insurance companies. Thank you, Bloomberg Businessweek. Whatever else you want to say about them, they are not some left-wing propaganda organ. And that doesn't even count for the 12 million hours a week it's estimated that we, the patients, are spending on the phone with insurers. The costs of private health insurance are escalating much more rapidly than Medicare and Medicaid is shown here. And taken together, this needless bureaucratic wasteful spending is responsible for about half of the difference between what we're spending and what they're spending in Canada, if you think of that earlier graph. Number two, high out-of-pocket costs with private health insurance and their consequences. So this graph shows us in 2021, the average worker was enrolled in a family health plan that was costing a total of over $22,000. Their share of that after their employer kicks in is about $6,000 a year. That's out of their paycheck, and you can see how that's grown over the previous 10 years. Here in Massachusetts, we have seen a 276% rise in the employee premium contributions to their employer-based plans over the past 20 years. That's as opposed to a 50% rate of general price inflation. Deductibles have quadrupled over the same period of time. And if you're in a high deductible plan, you can expect to spend somewhere north of $4,500 cash out of pocket before your insurer puts up a penny if you're in a high deductible plan. So here's an example. A family that's privately insured, fully insured, who has a normal childbirth can expect to spend an average of $3,000 cash out of pocket above and beyond what their private health insurance is paying for a normal delivery. for maternal and child care. What are the consequences of this? People stay away from care. There's no question about it. The data are there. When you make people pay out of pocket big time, they don't access care in the way that they should. And you see it across the board. There are drops in utilization of preventive visits, office visits, mental health, emergency, across the board. Necessary care and so-called not necessary care, it doesn't matter. People will stay away. They can't make that judgment. They just know they can't afford it. Here's an example. The National Bureau of Economic Research put out this study last year. They calculated that an increase of just about $10 per prescription of certain life-saving medications translates into a 1/3 increase in monthly mortality. Again, there is a body count to these excessive out-of-pocket expenditures that are placed on the entire patient population. Underinsurance is the norm with private health insurance. If we look at this orange wedge here, 23% of those with private health insurance have basically are spending 10% or more of their annual net income on healthcare expenditures, and that's above and beyond what they're paying for their premiums. 23% are spending 10% or more of their annual net income to pay for these expenses. Half of private insurance is for profit. Bernie Sanders put up the number that meant that over $100 billion a year was being sucked out of our healthcare spending to go right to investors. And that's likely an underestimate, according to other experts. Where does that money go? Well, some of it goes to pay these multi-million-dollar paychecks, annual paychecks to these CEOs that head for-profit insurers. Is this where we want to be spending our healthcare dollars? I don't think so, not from a public health point of view. For-profit hospitals cost more, almost 20% in this set of data. And if we're talking about renal dialysis, for-profit renal dialysis operations have a 7% greater mortality rate. That adds up to almost 4,000 excess deaths due to profit. And why is that? It's very clear. You can't serve two masters. You're either going to manage your care delivery to optimize the outcome for the patient or to maximize profits for your investors. You can't do both at once. You can't serve two masters. Can't be done. Finally, there's continual churn. In one study in Michigan, in 1 year, 28% of workers with employer-based insurance changed plans, either because the worker had a change of job status or the employer changed the plans that were available. That is a terrible thing for continuity. And speaking as a primary care, now retired physician, I can tell you that continuity is very important. But we hear people love their private health insurance. Oh, really? Well, luckily, we don't have to speculate. We have some data that we can look at. Here's a study from last June in the JAMA Network Open Journal. In this survey, individuals with private insurance were more likely to report poor access to care, higher costs of care, less satisfaction with care compared with individuals covered by publicly sponsored insurance programs. How about that? That's what the data tell us. Now, I want to be sure that when we're talking about Medicare for all, we do not mean expanding the Medicare program as it's currently configured to cover all age groups and not just seniors like me over the age of 65. That is not what we mean. And why do I say that? This is very important because there are problems with Medicare as is. Number one, it's not comprehensive. Part B, which is clinician fees, only covers 80%. That means you have to purchase additional insurance, supplemental insurance, which means it's complicated, it's expensive, and it allows the for-profit insurance giant companies to make profits off of this nominally public program through the Medicare Advantage option. Now, when I signed up for Medicare, I was sent this helpful graphic in email. Medicare informed me that I could expect to spend cash out of pocket over $6,300 a year for the premium from a traditional Medicare, my supplemental plan, and my Part D drug plan. That's for my public insurance program, $6,300 plus. And that's if I'm healthy. That's if I don't have any other expenses during that, or don't get sick this year, which I hope I don't. I was more recently sent this from Medicare that it's time to compare it's open enrollment season. I have 27 Medicare drug plans I can look at. Do I want to do that? Am I equipped to do that, even though I'm a former physician? I'm not. And you know what? Neither is anyone else. 71% of beneficiaries don't compare plans. Why? Because it is hopelessly, needlessly complicated. So it is no surprise that in 1 year, 23% of US seniors citing costs didn't go to the doctor when they were sick, didn't get a prescription or skipped a dose, didn't get a recommended test or medical treatment. That's why we want to talk about improved Medicare for all. That's what we're talking about. We mean single payer. What is single payer? One payer, the government, either the federal government, the state government, or a combination, picks up the tab. Global budgeting for hospitals and nursing homes, like the fire department. The patient sees a free choice of doctor, clinician, and hospital. Uniform fee schedules for individual clinicians, price controls for drug companies. This cartoon appeared in the Boston Globe during the Clinton effort at reform. Gosh, Bill, if only there were a fair, efficient way to give everyone quality, affordable health care. They never considered anything about the Canadian example. Not that we have to duplicate Canada, but they never considered anything in that direction, nor did the Obama administration. But we should look at it and look at what the experience has been in Canada, because they have been much more successful in controlling their costs than we have here, as shown in this graph. And their outcomes for certain measurable conditions is better than ours. Cystic fibrosis is a good example because it's very intensive of medical management. People with cystic fibrosis in Canada are surviving an average 12 years longer than they are in the United States. And there are many other examples of this we don't have time to get into. I will just mention, because we're talking about the state bill, there is a national bill in the House of Representatives introduced by Pramila Jayapal. It's HR 1976 to establish an improved Medicare for all national health insurance program. The public is already with us. And this Ipsos Reuters poll from a couple of years ago, 70% support for Medicare for all. And in this poll, it included a majority of Republicans. They don't all show that, but this one did. More recently, Robert Wood Johnson from last summer, 63% support. The physicians are already there, 56% support for single payer in this Merritt Hawkins survey. The American College of Physicians, the largest organization of physicians in the United States after the AMA, it's the internist professional organization, now is recommending single payer financing. This is a great leap forward for us. And I would recommend that people visit the Congressional Budget Office site, because they just released last month an analysis that basically supports every point that we've made in this presentation. Congressional Budget Office is on our side. No co-sponsor of Medicare for All has lost re-election in the past decade, even in Republican-leaning districts. And I'll just end with a reminder that Healthcare Now is putting on its Medicare for All Strategy Conference starting this week and live on the weekend. And you can get more information and sign up for that at healthcarenow.org. Thanks for everybody's attention.
Thank you, Dr. Myers. Our next speaker will be economic professor Gerald Friedman of the University of Massachusetts. He is the author of the book, The Case for Medicare for All, and has drafted funding plans for single-payer health insurance campaigns in New York, Colorado, Pennsylvania, Rhode Island, Oregon, Massachusetts, and others. Without further ado, let me introduce Professor Friedman.
Thank you. Thank you so much. And Alan, hey, that was great. I really appreciate it, because I can go faster through some of my slides since they're duplicates of what you just did. I'm going to talk a little bit about the global problems that we've got, and then get specifically into some of the numbers for Massachusetts. And then conclude with a final slide with some of the limits of what I've done here. This, which is quite similar again to what Dr. Myers just showed you, is shows the rising costs of healthcare in the United States, which I like to date to when the economists started getting involved, because one of my favorite things to do, which is one of the most constructive things I do, is to criticize economists. Economists started getting involved in healthcare in the late 1960s after the publication of an article by the late Kenneth Arrow on healthcare and information, which I'll come back to in a few minutes. And then in 1971, at the instigation of Richard Zeckhauser at Harvard, the Nixon administration endorsed health maintenance organizations as a way to control healthcare costs. That was the idea anyway, and provide better care. Since then, everything's gotten a lot worse. And here, which is very similar to one of the slides that Dr. Myers just showed you, shows healthcare spending. Each diamond represents a different country in the Organization of Economic Cooperation and Development, the club of the rich countries. And here's healthcare spending, here's life expectancy at birth. And as you can see, and the regression line supports this, for the rest of the world, when you spend more money on healthcare, people live longer. The United States, this is actually true, though I only show a few states here, but it's true in the United States that spend more on healthcare, people live longer. But for the United States as a whole, compared to the rest of the world, we're doing a lot worse. We're spending a lot more than anybody else. No other country comes close. Here's Luxembourg and here's Switzerland. As you can see, we're spending over $2,000 more than them, but our life expectancy is shorter. At this point, if I was speaking in person, I would ask whether you want the $6,000 that we're spending above what a country with comparable life expectancy spends, or if you want the 4 years of life that we should be getting, given how much money we're spending. And what I've noticed is that old people like me tend to go for the 4 years of life. Young people with college debt usually go for the $6,000. What do kids know? What do they know? What's more, if you put these two graphs together, you get something like this, which shows how we're getting worse and worse since 1971, when the economists started getting involved. Nowadays, you can't do healthcare without talking to economists. I mean, even Dr. Myers, what does he do? He cites the Congressional Budget Office, a bunch of economists. Economists are all over the place, and they are all, well, mostly giving bad advice. And we've been listening to them more and more, doing things to associate the care people get with the money they spend. The whole idea is to treat healthcare as a consumption activity. And as Richard Zeckhauser once said in a seminar that I was at, he was the head of, at that point, he was head of the Kennedy School in between the Ford and Carter administrations. As he said, we don't subsidize skiing. So why do we subsidize healthcare? What is the problem with healthcare? Again, Martin Feldstein, another economist who's very involved in this, said the problem with healthcare is people are not paying for the care they get on the margin. The problem with healthcare, they're saying, is insurance. People should be buying healthcare like they buy other consumption activities. You know, listen to the language that people use, economists and policymakers. They talk about healthcare consumers. You know, I've been spending too much time in the doctor's office since I've been dealing with this long COVID thing. And I could tell you, I don't feel that I'm a consumer of healthcare. I feel I'm a sick person and I want to get care. Okay, what happens if you can't afford to pay for your healthcare on the margin? Well, this graph has every county in the United States a few years ago. And it relates age-adjusted mortality. So it's the death rate controlling for the age of the population. And on the horizontal axis, you have the proportion who report they could not go to the doctor because of cost. This is associated with health insurance, but it's not health insurance that matters. It's whether you can afford to go to the doctor. And if you can't afford to go to the doctor, you know what happens? You die. This should not be a surprise to anybody except an economist. I'm serious. Zeckhauser said, this is in 1980, all of the gains in life expectancy have come because of clean water. healthcare has had nothing to do with improving life expectancy. Well, that's obviously not true for countries, as you saw. It's not true for states within the United States, and it's not true for counties. Access to healthcare makes a difference. And here's the counties in Massachusetts. This surprised me a little bit because, you know, you think we're doing pretty well in Massachusetts, but excuse me. Debbie. I'm sorry. Within Massachusetts, there are counties where more people can't afford to go to the doctor. Fewer if you compare this graph's access with the previous graph. Proportion with cost-related access problems, proportion who cannot afford to go to the doctor is higher. More people die in Massachusetts. And actually, the line is steeper in Massachusetts. It matters more in Massachusetts than elsewhere. What's more, compared to other countries, we are actually losing ground. We've got all this wonderful modern medicine. You know, arguably, we still have the best hospitals in the world. People come to the United States, rich people come to the United States to use our healthcare facilities. Middle-class people from the United States go elsewhere to use their healthcare facilities because they can't afford those in the United States. We have got this whole medical tourism thing going on, Americans leaving to go elsewhere. That was actually in one of Dr. Meyer's graphs, graphics. And all over, people are doing better. We're reducing the number of people who die because of, because we have better healthcare. In the Netherlands, the avoidable deaths is down by a quarter, over a third, almost a third. In the New Zealand, it's down by even more because New Zealand is such a great place filled with hobbits. The United States is down a little bit. Yeah, we have more MRIs, we've got better facilities, we do a little bit better, but not much. The gap between us and the rest of the world is widening because despite that we're spending so much money, because so many people can't access the system. And this, you think rich people would be involved in this. They would sign up to get the system better because even the richest Americans have as high a proportion who cannot access healthcare as poor people in other countries. In fact, rich Americans are way worse off than poor people in most of the world, or most of the other affluent countries. So the system's not working. Why isn't it working? Well, the costs are too high, and then we pass on some of these costs, growing share of these costs, to consumers of healthcare. Why are costs so high? Administrative costs, definitely. I mean, we've been, in the single payer movement, the Medicare for All movement, we've been talking about this for quite a while, administrative costs. And I'm not going to spend too much time on it for that reason. Market power is even more important these days. Market power, we've been talking about it for pharmaceuticals. People like Senator Sanders have zeroed in, and the Biden administration zeroed in, and maybe we can go after pharmaceuticals. Okay, yeah, maybe. But it's the hospitals that are even worse. And I throw this in, even though it's not nearly as big as the first two, but it's fun. The overpaid administrators. Okay. Private insurance is inherently wasteful. I mean, God, people like Zeke Emanuel have been working on, how can we make this work better? How can we make the insurance system more efficient? And, they said, well, medical records, electronic medical records. That should be great. They tell you they really suck. Well, I don't need to tell you, you know that. Private insurance profits from waste. Private insurance necessarily is wasteful because that's how they make money. They make money by screening. Find the lemons and drop them. Identify the 10% of people who are going to run up 70% of your costs. What do they call it? They call it the medical losses. What the money they spend on our healthcare, insurance companies call medical losses. As Dr. Meyer said, you can't serve two masters. You can't serve profit and healthcare. Identify the cherries. Find the people who are going to be healthy and attract them. give them free gym bags, give them free gym memberships, bathing suits, whatever. Get them to sign up for your insurance policy. All this stuff costs a lot of money. They spend a lot of money on this. I had a colleague, a co-author, years and years ago, a very good sociologist. She left Stanford and went to work for Kaiser at double the pay of a full professor. Her job was to data mine everything Kaiser had on people and find the things that would drive away sick people. Monopoly pricing. What are you going to spend for something that's going to save your life? Well, chances are you'll try to find the money to spend. We call this highly inelastic demand. It's especially inelastic if you don't even know what's going on. They rush you into the hospital, and at some point, somebody's going to give you a bill. You're not going to be looking around for the cheapest one. I mean, it's crazy. And besides, you don't even have any choices about it. Out here, we have Bay State and we have Mass General Brigham. Those are the hospital systems. There's Holyoke, which is still independent, but basically there's very little competition. Doctors are increasingly owned, physician practices in great majority now nationwide are owned by hospital networks who use the physician practices to steer patients into their hospitals. Mass General, back in Partners days, when they were called Partners, claimed, we lose $70,000 on each practice. Well, why do you buy them? They buy them because they more than make up that money by steering them into Mass General, where they charge 4, 5, 6 times as much as other hospitals in the Bay State. There's no competition. And this is a major source of profit. And where does the profit go? It goes into their reserves. They buy up land in Boston. They build. They buy politicians. No, sorry, Lindsay, didn't hear that. And they overpay their CEOs. These data are from 2021. Anne Klebanski is a serious scholar and a physician. She deserves to make as much money as some of these other people. Why is she paid so much less? And it's not just gender, because Anthem's Gail Boudreaux is also a woman. Really? But that's, my God, what am I saying? $2 million up to $5.8 million if she gets all her bonuses. That's not enough money. God, what do people do with that money? That's a good question. Okay, how much will it cost to fix our system? Here's my method. It's pretty straightforward. Start with how much the current system costs and add the cost of universal access. That's, it's relatively easy to estimate how much it will cost to provide insurance for the uninsured. In Massachusetts, there are not that many, so that's not that, even if you make a mistake, it's not going to be that big a deal. The bigger issue is, how much will it cost if we actually did away with copays and deductibles and people could access the system? Access the system freely. That is the major area of controversy among those circle of people involved in this sort of research. Okay, then you take that money, how much it would cost to fund the current system plus universal access, get rid of administration of the health insurance system, figure out, well, if we had administration and processing paper for providers as efficient as Canada, you still have to have some administrators, you still have to have people handling scheduling, payroll, etc. But how much would we save? Monopoly pricing of drugs. Okay, well, if we paid VA prices for drugs, I don't assume VA prices, I assume something above that. But that's just because I haven't updated my numbers from a few years ago when drug prices weren't as out of hand. Devices, hospital devices, that's not as big a number, but it's huge. I just had this fancy procedure. Guy told me the new machine's a $2 million machine. Does it really cost $2 million? I don't know. Okay, hospitals. Oh, by the way, on drugs, I think today is the anniversary of the Salk vaccine. Extra credit if you know how much money Jonas Salk got for the patent on his vaccine that has saved millions of lives. Hospital prices and providers, providers not a big deal. Negative here. If we're going to treat all doctors the same, we have to pay Medicaid physicians as the same as we pay everybody else. That's going to cost extra money. Fraud. I don't know. This is a bit of a guess. People throwing different numbers around. But a single payer system could reduce fraud, especially using state subpoena powers to track down. We know that there's a lot of fraud in the system. The senior senator from, one of the senators from Florida his company paid the largest Medicare fraud bill fine in history, $500 million. Still got himself elected senator. Existing revenues repurposed, and then new taxes. Okay, 2021 without COVID. All this is without COVID. Personal health care would have been $91 billion. Improved access, $6 billion. Total personal health care with full access, $97 million. Add in administration for the insurance system, and we're up to $109 billion. Is any wonder that Mass General is the biggest employer in this Commonwealth? Savings, okay. We're lowering the prices of hospitals. Talk about, making enemies, but okay. $11.6 billion in savings. About $2 billion in physician prices. Physicians will end up getting more money by the end of this anyway. Drug and device pricing, $6 billion saving. It could be more than that if we got VA prices. Provider administration, $9 billion. Notice, if you go, next time you go to your doctor, look around the corner. And you see all these people who spend all day arguing with the insurance system about your prescription or your service. We're going to have to pay more to Medicaid providers. Insurance administration, this is the one that people have been concentrating on. And it's $10 billion. It's a lot of money in the Commonwealth, 9% of total spending. But notice, the hospital price adjustment is bigger, and there's as much to be saved within provider offices as in the insurance companies. I throw in a number for fraud. That's really a guess. I think it's a low gut guess, but whatever. I estimate we'd save about a third of what we're currently spending, and we'd end up with $75 billion. To that, I would add, if we're going to get Medicare to pay the Commonwealth for Medicare recipients, then everybody has to be on Medicare Part B. So, and you can't get people to pay for Medicare Part B if it's not going to make any difference for the services they receive individually. So we're going to have to put in some money for that. Okay, all of this is going to make enemies. And you wonder, why haven't we done this yet? Since we'll save lives, since doctors will be better off, patients will be better off, the economy will be saving money. Why don't we do it? Well, hospital networks like Mass General. People getting $2 million, $20 million a year, they're going to fight this like hell. Not to mention the drug companies. Not to mention some highly paid specialists. I was once driven around in Colorado by an oncologist. And she explained to me that she was the only oncologist who supported single payer. PNHP is filled with internists and family practice doctors, but specialists fear that they will be losing money when these price adjustments are made. Poorly paid staff might be scared that they're going to lose their jobs. I mean, there are better jobs than what they've got, but don't quote me on that, please. Okay, Medicaid price adjustment. Hey, doctors and hospitals are going to win, but not all. Safety net hospitals will be big winners. Holyoke will be a big winner. Mass General, people used to say about a similar hospital in New York that their Medicaid plan was a taxi ride to a public hospital. So the public hospitals, the safety net hospitals will be the ones who will be getting the Medicaid price adjustment. Insurance companies obviously will lose. They'll go out of business. And cheaters will lose.
Okay, we're
Overall, almost done. Okay, so here's where we got the money. $56 billion. It repurposed existing monies, and then taxes. It would help if everybody paid their taxes. This is a bit noir of mine, but okay. We need 19 billion. I estimate we'll raise 26 with what's in the bill, $6 billion extra. The middle class will get a big tax cut. The poor will benefit. The rich will pay more. The program is progressive, given that the rich have been doing so well lately. That's fine. The public saves money. Cities will save money. Towns will save money. The town of Amherst doesn't do that well, but okay. The Commonwealth will save money. There should be an increase in personal income. People will be healthier, they'll be more productive. And the economy will expand if businesses don't have to pay so much for health insurance. And finally, the limits of this analysis include COVID. Everything's based on pre-2019 data. Long COVID course. Millions of Americans are experiencing some form of protracted COVID. What's that going to do to long-term? We hope everybody will be healthy, and the speed of transition. I'm assuming we do it like that instantaneously. That's not going to happen. So we're going to have to build in a longer transition plan. Read my book, write to me, follow me on Twitter. Thank you so much. And thank you for giving me extra time.
all right. Thank you, Professor Friedman. Okay. Our final speaker will be David Cohen from Franklin County, Continuing the Political Revolution. He is a member of the board of MassCare, a coalition of Massachusetts organizations working to establish a universal healthcare system in Massachusetts. And he will be addressing what we can do to keep the momentum going for a Medicare for all system in Massachusetts.
Okay. Hello, everyone. I'll try and share my screen here. People see that now? Okay. So thank you, everyone, Chris, Lindsay, Alan, Jerry, for giving us all those great facts on Medicare for all, why we need it. I'll just try and quickly address, one of the things we're currently doing in order to build the movement for Medicare for all in Massachusetts. So MassCare is a coalition. It was born in 1995. There are 40 organizations that belong to MassCare. We really have started in the recent period wanting to build local groups, and our real plan would be a local Medicare for all group in every state representative district in Massachusetts. Our basic theory that we have is that we have to build a mass movement. We have to build a big enough movement to either win this through the legislature or through a ballot question. But in any case, we have to make Medicare for all the predominant ideology of the majority of people in Massachusetts. We believe that pretty much it already is right now. And we're going to talk about one of the tactics MassCare is doing this year, and we've done in previous years, is using the non-binding ballot question, a public policy question. In Massachusetts, you can put questions on a state representative district ballot in November, and it's giving instructions to your state representative on how they should vote on issues. I like to believe this harkens back to early days of the revolution. Sam Adams used this as a tactic to hold public meetings and give instructions to legislators on how they should vote. So in Massachusetts, we can do these public policy questions. They're non-binding, but they give instructions. And we've done this in the past. Last time we did it really in 2018. We did it in several state rep areas in Western Massachusetts, and it passed by 72% on average. So why do we want to do this? We want to educate people about Medicare for All and the potential to have a Medicare for All system in Massachusetts. In areas where a state rep or senator is not a sponsor of the legislation, we want to let people know that, and we want to bring pressure to bear on these state reps and senators to sign on to the legislation. Right now, we have about 40% of the state reps and senators, state senators, co-signing the legislation for Medicare for All. We want to bring people into an organized movement so they can help work for Medicare for All. And of course, we want to demonstrate that Medicare for All has wide support in the district. Here's what the ballot question will look like. This is from 2018, but the question will be the same. Shall the representative from this district be instructed to vote for legislation to create a single payer system of universal health care that would provide all Massachusetts residents with comprehensive health care coverage, including the freedom to choose doctors and other healthcare professionals, facilities, and services, and that would eliminate the role of insurance companies in healthcare by creating a publicly administered insurance trust fund. So this is the question that's been on the ballot in various forms over the last 10 years. What do we have to do to get on the ballot? In a state rep district, we have to collect 200 signatures from valid voters. In a Senate district, you have to get 1,200. After they're collected, they have to be submitted to a city or town for certification. Then they have to be collected back up and turned into the Secretary of State. And then if they're approved, it appears on the ballot in November 2022. Our point of view is that it's not enough just to get enough signatures to get this question on the ballot. We have to get out there and campaign for it. We have to, and here's some examples. You can make Medicare for All presentations. We've done them at many at public libraries. People have gone door to door, knocking, handing out literature. Especially in November, it's election time, so there's lots of meetings with candidates that you can go to. During the summer, it's a great place to go to farmers markets and pass out literature about Medicare for All, and holding other sorts of meetings. We've had great experience doing that. Here's the basic timeline. We're right now, January through March, we're starting to organize people in various state rep districts who will get out there and do the signature collecting. April 26th is the kickoff date. We get the petitions from the state of Massachusetts, and we have through June to collect the signatures. There can only be 3 public policy questions on the ballot in any state rep district. So we're urging people to get out there and collect the signatures and turn them in early. In July, I think it's July 3rd, I believe is the date, they have to be turned into the Secretary of State's office. And then July through November, we campaign for a yes vote on the ballot question. And afterwards, after it passes, like I said, our experience is where we get out and put out literature and talk to people about this, the Medicare for All question passes by 70-something%. I think we had one town in Western Massachusetts where it got 85% of the vote. And then in November and December, we'll follow up with the legislators, especially those aren't on the bill, co-sponsoring the bill yet, and we'll ask them to co-sponsor the legislation. So what can you do? What we're hoping people will do, you can join MassCare. You can start campaigning to get Medicare for All on a ballot in your district. You can donate money. I'll put in the chat, I'll put some links to where you could go to sign up for the campaign. Our experience, let me just say, our experience has been that there's widespread support for this. We have forms that people can use to calculate how much a local city and town would save. Some of the things that Jerry showed you. It has a big impact. You know, when you, especially you go to a city or town. I live in Greenfield, Massachusetts, population 17,000 people. Greenfield would save $4.2 million a year if we had the Medicare for All system. It would be an automatic pay raise for the employees because, you know, employees, state employees and municipal employees have to pay part of the health insurance. So it'd be a pay raise for employees. It would just create the conditions where the city and town could do more with the money they have. So I'll be glad to answer any questions. We're aiming to get it on the ballot in about 25 different districts in Massachusetts this year. We already have, I believe, 17 that we have committees of people working on, and we're still aiming to get more. So I will thank you for that and gladly answer any questions.
Thank you, David. Okay, our first question is from Timothy McLaughlin of Plymouth, Massachusetts. Timothy asks, how do we address wealthy pro-business lobbyists who have millions of dollars to fight Medicare for All becoming a reality? I would like to address that question first to Representative Sabadosa and then to David.
So how do we fight lobbyists who are trying to prevent Medicare for All? Is that the question?
Basically, yeah.
So not a small question for sure, and definitely that is the challenge that we are facing. However, I do believe that things change when we have enough people on the ground pushing for them to change, irrespective of whatever entities are pushing against us. But it's a large percentage, right? I mean, we have a meeting this evening with 26 people here, and I would argue that we probably need about 3% of our population, which is small but mighty, to actually get government to listen and say that our current system is not effective. And once we have that level of groundswell, it's not going to be impossible. We're seeing that happen with certain industries already, but it is going to take a lot more grassroots organizing and a lot more people just really demanding radical change from our healthcare system.
Yeah, I would just add, I mean, I think that Lindsay's absolutely right on that. And this is the strategy of MassCare. We have to build a big enough mass movement so that we can overcome I think there's two things. There's one, there's money that some elected officials get from, you know, campaign funds, but there's also this prevailing ideology that, you know, they think they can't make any change. And of course, making profit off healthcare is okay. We have to make it so that the prevailing ideology is one that says healthcare is a right. Healthcare should not be, you know, concerned with making a profit off of keeping people healthy. And that should be the basic ideology. And so we have to get out there and build that kind of movement. And, you know, in the final position, if there are areas where the majority of people support Medicare for All and the legislator refuses to go along with it, then we'll have to run someone who will support Medicare for All against that legislator. And I think that's where ultimately our power is going to come from our organization.
Okay. David, Aaron Cohen asked, what is the strategy for getting unions behind this? In addition, I would add to that, what would you say to a union member who says that they're satisfied with the healthcare plan that they currently get to from a union, and they don't want to, and they are worried about losing their benefits under a Medicare for all system?
Sure. Well, I spent 45 years as a union person, organizing the factory I worked in. And then when that factory moved to Mexico, on staff of the union for the United Electrical Workers, I probably negotiated 1,000 contracts over that time. I don't think there are many workers who are going to say that they're happy with their healthcare, their insurance. And I'll just tell you this quickly. A couple days ago, I found going through some old folders, and I found a little newspaper article, and it was about the factory I worked in, and we had just negotiated our second contract. And our goal in the second contract, which we won, was to get fully paid by the company health insurance that had no cost to the workers. Right? This is 1976. And I was thinking, you can't get that kind of health insurance anymore. The insurance companies do not offer plans that says the employer pays 100%. They all have massive deductibles. They all have co-pays, right? We have gone steadily backwards. And anyone who's been in the labor movement knows how, what proportion of your pay ends up going back into the insurance companies. I think the latest figures I saw lately for a family plan, it costs about $10 an hour for a family plan insurance. That's a pretty healthy chunk. And I don't think there are many workers who haven't been in the situation where every bargaining session, every contract they go through, the question becomes, do we get a pay raise? How much more are we going to pay in health insurance? How are we going to take in cut in benefits? Right? And you're weighing those questions. So I think union people are going to support this. I have to say our biggest supporters are MassCare, the Massachusetts Teachers Association, the Mass Nurses Association. They are helping us, funding us with this quest. So I think, and we have a labor committee of MassCare that people could get in touch with me if they want to join that, if they're a union member. And we're making presentations to unions, and unions are going along with it. They see the benefit of taking bargaining for healthcare off of the table, and having, being able to spend their time bargaining for benefits and better wages.
Okay, thank you. Representative Sabadosa already addressed this in the chat, but just so people can hear it, we have heard that a single payer plan in Vermont failed. Can you provide a simple explanation and say whether that situation is relevant for Massachusetts? If Representative Sabadosa could address that, and afterwards, if Professor Friedman has anything to add, that'd be great.
Sure, I was going to say there may be others who are more eloquent on this subject than I am, but it is my understanding that the Vermont legislation did not include a robust financing plan, which was one of its downfalls. The Massachusetts plan is very clear about how we pay for that, and thanks to Professor Friedman, we have very clear numbers that anyone can go to sort of look at how we're going to make sure that we can cover all the care that we're offering. I would say that having done a little bit of research into this, I think that there were also political pressures. And so, really making sure, I think, as David said, that we have legislators who really believe in the system, that we have a governor who really believes that it's the time to move forward. It feels like it is indeed feasible. But I will pass it over to Professor Friedman to add more.
Yeah, thank you. Everything you said is right. The original proposal was costed out by Bill Shao and David Gruber at Harvard and MIT. And this is in 2011. And they proposed that it could be done, a single payer system in Vermont could be done with a payroll tax of 11.5%. And then the legislature voted to establish this committee that was to work out the details and go ahead with it and present a proposal for the final program. At that point, the activists who had been pushing for the single payer bill, I don't want to criticize, but it seemed to me that they rested on their laurels. They felt like, okay, we're done. We did it. And then for the next 4 years, the governor, Shumlin, went around and other people went around talking about, okay, we're going to do this, we're going to do this, it will be great. And they never got around to talking about the money. So then when the Green Mountain Care Board, I had been put forward. Beyond that, I didn't make it since I was involved as a supporter. When the Green Mountain Care Board came out with their proposal that included an 11.5% payroll tax, everybody's like, oh my God, it's going to cost so much money. But that was exactly what it was originally talked about. It's just that for years, people had not been involved, not been pushing it, and hadn't been talking about how much it was going to cost. Now, 11.5% is still going to save money for most people in Vermont. Nothing had really changed except coming face to face. So I think the lessons from Vermont are, first of all, never stop. When you get your energy going in the grassroots, you got to keep going, because the opposition is going to get harder and harder the closer you get to accomplishing anything. This is what we've seen in California, in New York, in Massachusetts when we had the referendum 15 years ago. And second, you have to be talking about the money from the beginning, because while everybody cares about their health, everybody also cares about their bank balance. And you can't not go into that. People have to be assured that you are on top of the financing. And I think those are the two mistakes they made in Vermont. One final thing there in Vermont, when it happened that it fell apart, I told people I'm going to spend the rest of my life explaining what happened in Vermont, and this is never going to go away. And it's like the second or third question that always comes up.
Yeah. Another Professor Friedman, someone else asked, we are often told by legislators that Medicare for all it can't be implemented because at the state level, or that it's too complicated. You pretty much gave a presentation on that, but if you have anything else to add.
Yeah, well, it's too complicated. It's like, insurance is offered in a much more complicated way than we're talking about. We're simplifying things. And the state is certainly capable of handling a large insurance program. 20% of the residents of the Commonwealth are on Medicaid, Medicare already. So plus, another 100,000 in the Group Insurance Commission. So it can definitely be handled by the state. The state can negotiate, the state can write checks, the state can collect money. People who say it can't be done on the state level do hand waving about you need federal authorization and you need to deal with ERISA, the Employment Retirement Security Act of 1975, whatever, which restricts state regulation of interstate companies' insurance plans and benefit plans. We don't have to ban private insurance, which would interfere with ERISA. We can if you want to pay your taxes and also collect money from your employees and provide a redundant insurance plan, then we don't need to stop you. But why on earth would anybody do that if everybody can get insurance through the state and healthcare through the state that's better than any insurance plan that anybody would be offering anyway. So ERISA is not an issue. Getting the money from the feds for Medicaid is not an issue because Medicaid is a state plan already. So it's only a matter of negotiating with the feds on Medicare. And we can do that. We can establish a Medicare Part C program on the state level that would funnel. You can't compel people to join this, but it would be a better plan than anything they're being offered. So why wouldn't everybody take it? And we would offer as a bonus that will pay your Medicare Part B premiums for you. So, and if somebody doesn't want to, if somebody insists that they're going to go outside and take their Medicare money with them, then, well, one less bill to be paid by the state. So, if you want to be silly about it, then go ahead. But I don't think very many people will. And it wouldn't affect the financing. It wouldn't hurt the financing any. We just wouldn't be paying their bills. So it would save money. So I really don't see complication or federal relations as a major issue.
Okay. Dr. Myers, I would just ask if you had anything to say about the hospital industry and where they would stand on Medicare for all, and whether they'd be whether they would be helpful or harmful in the fight for Medicare for all, and what Medicare for all advocates like ourselves should do about it.
Yeah, it's a good question, and I wish we had a bunch of hospital CEOs here that could weigh in. But it would dramatically affect how hospitals operate financially, in that they would be funded. They'd get a projected budget for the coming fiscal year, and they would, first of all, they'd have a huge amount of savings. In that they don't have to track on every expense. You put a catheter into a patient, and somebody has to bill that to the patient's insurance and maybe fight with the insurance company over it. So hospitals have to devote major resources to these kinds of making administrative connections with insurance companies and pursuing them and negotiating and fighting. All of that goes away. And it becomes a vastly different process of being granted a budget and then being able to work with that. It's now, how are people going to respond to that? I think it remains to be seen, but I think the Canadian experience was very positive, and I don't expect it would be much different here. I mean, I am not a hospital administrator, I have to say, but the task becomes one of really pulling your hair, fighting with insurers to get reimbursed for the services that you've delivered to patients. And it becomes one of planning how we're going to allocate the budget that we're being granted in advance. Now, there'll be some negotiations around that. It's based on what the hospital spent in the past, what did the last year's budget look like, and what are the changes that are planned to be made. But I would predict that that's not where, based on my limited understanding of hospital administration, that's not where the resistance is going to be, except for the for-profits. The for-profits have to be gone under this scheme. And as I said in the presentation, profit and healthcare and public health, they just don't mix on almost any level. Profit should be removed, and that includes, there's a for-profit hospital association that's part of this Partnership for America's Healthcare Future, which is the major organization, the major organized effort fighting against single payer at the national level, and the for-profit hospitals are part of that. They've got to be out of this.
Yeah, if I could jump in there, I'm less sanguine about opposition from the hospitals. The not-for-profit hospitals, yeah, they behave better, and their CEO salary, as we saw from Mass General, is a bit less, but they're still largely not taxed. That's the major difference. They've been piling up, and this includes Mass General Brigham, has been piling up reserves, squirreling them away. And I think practitioners would love to not have to deal with insurance companies. I think nurses would love not to have to spend all day on the phone, no question. But hospital administrators, whatever they say, they're not earning $10 million, $5 million, even $3 million because they are nice people. And, they're earning that money because they are negotiating with the insurance companies. They're doing all sorts of things that are basically a complete waste. They're driving up prices. They're putting up the ads on the billboards on the side of the highways. And they're getting a lot of money. And I don't think that they're going to roll over and give up. And they've built networks. I'm just saying we need to be prepared. They have media networks. The people who design those ads. You get off Route 91 at Route 5 in Northampton. There's a giant sign, Cooley Dickinson's now part of Mass General Brigham. The person who designed that sign got money from Mass General. The newspapers and the TV stations that have ads for hospitals, complete waste. Who needs these? But those are people, the banks and the finance companies that are processing all this money. There are a lot of people making money off of our wasteful healthcare system and the hospitals, and they're going to be fighting about it.
Okay, I would like to thank everybody. I think we're out of questions, and this has been a wonderful night, and we've had 4 wonderful presentations. If anyone is interested in further joining this movement, you can go to ourrevolutionma.com and also you can go to the MassCare website in order to sign up to join the non-binding ballot initiatives. And as David said, Healthcare Now will be holding a strategy conference on Medicare for All